leading a CRF project for young people excluded from education, employment and training. And I'm also an associate consultant with Neil Morland Consultants as well. And I think this is a really exciting project. Locally in Stoke-on-Trent, I was involved in the steering group for the Everyone In project as part of COVID, which was about getting people experiencing street homelessness off the streets and into accommodation to help avoid the risks of COVID-19. And there was a lot of work done on that in relation to sorting people into hot and cold sites with clinical input from local nursing staff, which was fantastically successful. And the heavy toll we were expecting in relation to COVID and homeless people locally, we didn't see that. So I'm really interested in this topic, and it's very important, obviously, for us to generate learning from experiences like the pandemic, because obviously, thankfully, there aren't too many opportunities to do that. So we've got some excellent speakers. There's a slight change to the running order. So first, I'm going to introduce Professor Siddhartha Bandyopadhyay, who's Professor of Economics at the University of Birmingham.
Yeah, thanks very much. Do you want me to start straight away? You want to introduce the other speaker?
Oh, of course, yeah. And then later we'll have Dr. Richard Machin, who's the Senior Lecturer in Social Work and Health at Nottingham Trent University. And Sid has to leave us early, so we'll take questions after the first presentation as well.
Yeah, thanks very much, Andy. I'll now try to share content. Okay, are you able to see my screen now? Yeah.
Yes.
Fantastic. Okay, well, thanks very much. What I'm going to do is I'm going to talk briefly about two recent papers that I've co-written, but in the context of why, that sort of sheds some light on deprivation and differences in outcome and experiences of COVID. When you hear some of the sort of line being put forward in official channels, and I can perfectly see why that they would, or even sometimes in media, you'd say, well, COVID affects everybody. You see, even Prince Charles had it. It reminds me a little bit of Animal Farm. Yes, all animals are equal, but some animals are more equal than others. So that's a bit like saying, oh no, everybody is sort of equal. COVID is a great equalizer because it can affect everybody. And I'm thinking, well, yeah, in principle it can, because obviously the virus can attack anybody from the prince to the pauper. But it actually, through the channel of inequality, COVID actually does discriminate. Who gets the disease is not random. It's determined by a host of factors, which are not random. How one fares if one gets the disease in terms of being able to properly isolate and recover is not random. It depends on socioeconomic factors. And why therefore we have these differences in exposure and outcomes is really important. And that's what I'll first briefly discuss and then make some more general comments and conjectures. So the first thing is, well, let me just, yeah. So let's look at some of these issues in sort of like a snapshot of the first paper we wrote on this, which looks at the impact of ethnicity, deprivation, and also importantly how ethnicity and deprivation interact to create sort of, if you like, unequal outcomes in the age-adjusted mortality rate for COVID-19. So before we wrote this paper, it's kind of been discussed in many circles that the BAME population are at an increased risk of developing COVID and consequently more severe outcomes compared to the white population. For various reasons, I think in terms of case numbers, it's just recently flipped for a number of reasons, which I'm happy to sort of discuss. And the aim of the paper was to say, well, okay, we know this, but can we quantify what's happening? Is it happening because there's something about ethnicity, some kind of whether it's a shorthand for some kind of health underlying health conditions being correlated more with certain ethnicities, whether it's because certain ethnicities are more deprived. Can we quantify this relationship? And that's what we basically did in this paper. It's an ecological study using local district authority district data in England during sort of the first phase of COVID. And the aim was to quantify how much of the age-adjusted death could be explained because of ethnicity and how much because of deprivation, and for that matter, its interaction, with a little bit of understanding also of any kind of spatial spillovers. So, whether there was a correlation between the age-adjusted death rate in one local authority with a neighboring one. So what did we do for that? We examined how age-adjusted COVID-19 mortality depends on ethnicity deprivation and the interaction between the two. We used a linear regression. Now, obviously, at that level, there weren't a host of covariates we could control for, but nonetheless, we controlled for population density and education. And then we also tried to understand, as a second aim of the paper, the spatial effects, to quantify the effect of local authority sort of spillovers from one to the other. Our main result was that LADs with the highest deprivation quartile, so communities had a much higher age-adjusted mortality compared to respective control population. And definitely ethnicity mattered. There are a bunch of results in the paper, and it's open access, so anybody can read it. But I'll just give you one or two highlights. For example, a 1 percentage point increase in the Black African population in any LAD led to 2.86 more deaths per 100,000 population. I report the confidence intervals in brackets. You do the same for Black Caribbean. The coefficient is actually even higher, 9.66 more age-adjusted deaths. For the Bangladeshi population, it's around 2 more deaths per 100,000 population. So yes, even when you control for deprivation, ethnicity matters. But then conversely, and perhaps more kind of, when you control for ethnicity, there's still a role that deprivation plays. The spatial regression results we also thought were kind of interesting in that if you look at the spatial map, I should probably have put up a map to show that actually if you see, it's actually not random. The sort of COVID hotspots are not random, and there's correlation between one LAD to the other. And again, that if you see, deprivation is also not independently distributed across the country. So, it might well be mirroring that. Okay. So what's sort of the punchline of the paper? Well, the punchline was that we wanted to see that, all the sort of headline figures about BAME populations and deprivation, are we able to actually quantify that? And yes, we are, and we're able to show the effect of ethnicity and deprivation separately, and as well as show you that you can actually, the interaction between the two. So if you happen to live in an area which is sort of a high proportion of BAME population, and you're in a deprived area, it's like almost like a double whammy, and the age-adjusted death is even higher. Now, what the paper couldn't do, obviously, because we didn't have data which would correspond to that level, is what are the mechanisms behind explaining this? And some of it could simply be that certain socioeconomic groups are at higher risk because of underlying comorbidities, which in turn might be driven by deprivation. So that could be one explanation of why you see these differences. The other could be occupational choice. I mean, for example, the BAME population was disproportionately represented in certain occupations in the medical sector, but also not in the sector which is well protected. Well, even parts of the medical sector initially. Remember, this was the initial phase, our data, where there were huge amounts of issues around PPE and so on for medical staff. And obviously, those who were medical affiliated working in hospitals were even less protected. So that could explain some of the differences in mortality. Mind you, except in this most recent round where things have actually flipped around a bit, this issue around ethnicity and deprivation continued through the second and the third wave. I think, funnily enough, it's flipped a bit, probably because there is, many of these people have already been affected once or twice and might have developed some natural immunity, and therefore, in this wave, they might be actually less affected. But there are all kinds of other unobserved issues in terms of exposure and risk, which are correlated with inequalities. If you live where you're not able to isolate well because you live in a very small, congested place, or because your house doesn't have enough rooms for you to successfully isolate if somebody else in the family has it, all of these are related to deprivation and inequality. So, whatever people say that COVID doesn't discriminate, in fact, it does discriminate, and I think the paper goes some way towards quantifying that. For sure, Prince Charles would get it, but the outcomes of the prince and the pauper, so to say, will not be the same. The other thing which kind of struck us that, well, if certain population groups are at higher risk of getting COVID, would it be the case that they would be more eager to get vaccinated? That's what ordinary risk calculation shows. But we know that that's not the case. And when I'm looking at the implications, that almost sort of led to the sort of next paper that we did. We do need targeted public health measures to support those most at risk, right? That's what my co-author George Chandan, who's a public health person, always keeps saying. But as he points out, if you do want to target public health initiatives, you have to make sure that people actually want to take advantage of that. And for that, you need to sort of trust authorities or trust the government or trust people who are telling you to do things. And that's sort of the basis of our second paper, that if you don't actually trust people, if you don't trust authority, and sometimes with good reason, just having public health measures or having the availability of that is not going to help. So that kind of led to this second paper where we were discussing, well, we know that BAME groups are at higher risk from the early data. Why aren't they more willing to take vaccines? And as a political economist, it struck me that surely one of the reasons must be related to do with trust in government and trust in institutions. I mean, that's generally for all of us, and I'm sure most people, regardless of political affiliation, would agree that the recent events around government haven't exactly improved trust in government. But nonetheless, some people could have even lower trust in government, and could they be actually coming from certain ethnic groups? That was sort of the basis of the second paper, which is on vaccine hesitancy, which has just come out last month. Around, can we actually quantify this? And to do this, we were able to find a survey which has all these things around, whether you're willing to take a vaccine or not, looking at education, looking at financial status, but also looking at whether those respondents, in some sense, trust institutions. Okay, so that's the basis. I'm just going to quickly go through it and then make some general comments and open up for discussion. You need public acceptance. So the vaccine generally has been a success story, but you need public acceptance and willingness to be vaccinated. And in spite of the fact that over time actually vaccine hesitancy has gone down, there is still a lot of inequality in willingness of people to be vaccinated across local authority districts. What we want to understand is, again, is this correlated with ethnicity, but also go behind this a little bit and try to understand what is driving vaccine hesitancy in certain groups. So what we did was we looked at a cross-sectional study using data from a UK population-based longitudinal household survey. It's called Understanding Society COVID-19 Study. And this was sort of the time period of our study. We had about quite a good number, over 20,000 participants, even after checking out where we had missing data on variables. And then we used the logic model to describe the association between willingness to be vaccinated and public sector or government mistrust. So the actual question was, do you trust public officials? And another question which you also used was, do you think that the government actually, that you have a say in government? So you wanted to capture one of two correlated things. Do people actually trust governments or institutions or public institutions? And second, do they feel part of society, part of institution? Do they feel sort of, disenfranchised, so to say? Because that's a real problem if they do. And we found two things. One, that as reported, we did confirm that actually people from BAME groups are less willing to take vaccines, but also importantly that positive opinions towards public sector officials actually increases. So if you're either neutral or positive about public sector officials, you're more willing to take a vaccine. That was actually correlated with being in BAME groups. And the other things that played a part were education, more educated, more willing to take a vaccine. Younger age group, slightly less willing, not surprising. That's ordinary risk calculation. And this was important. Subjective perception of financial status. If you believed that your financial well-being was not so great, then compared to those who believed it was okay, or at least okay, you're less willing to take a vaccine. That might again correlate with general disenfranchisement. It might correlate with not being able to take time off work. It might be a kind of very precarious employment situation. But those are the other factors than trust which mattered. What's important is, while trust varies across ethnic groups, once you control for trust, so suppose you are from a BAME group, but you do trust the government, right? Maybe some of the younger people do. Maybe they have had historically less adverse interactions with the government. Then actually ordinary risk calculations completely consistent. You're from a BAME group. You are at least neutral or positive about public officials. You're actually more willing to take a vaccine, as you would have expected. So the real driver of vaccine hesitancy, once you control for other things, seems to be a lack of trust in public institutions. That's a problem, not just for vaccination. It's a problem for any kind of policy around inequality, around, policies around government. Because if you don't actually believe the people who are running policies, and sometimes for very good reasons, policy is not going to work. I think that's a real problem around the fact that people do not trust institutions. And, there are no magic bullets around this. Happy to have discussions around it and completely understand why people do. And I think, going forward, public policy cannot ignore this issue around institutional trust if we are to make, progress around this. we also wrote a blog version of this, if anybody wants to read. I mean, it's a bit less dry than the BMC medicine paper. I realized, writing papers now with co-authors in medicine, how dry some of the papers are. So, but I think the blog's a bit less, where we discuss reasons around this and, how to improve institutional trust. I'll leave it at that and take any questions and comments. And sorry, I have to rush off right after Richard's speech, but my email is public information. So if we run out of time and you want to get in touch with me, please do. I'd love to hear from you.
Thank you. So we'll take 5 minutes for questions, and if people could put those in the chat, then that would be fantastic. Or as we've got the mics enabled, if people could raise their hands, and then I'll bring them in.
You've stunned them all into silence, Sid.
Yeah, I know. I just steamrolled. There's nothing. Oh my God! After this, life's not worth living. No questions.
Sid, it's not so much a question, but a reflection. I was involved with the RCP report a few years ago. Every Breath We Take, and one of the chapters in there considered inequalities, and there was an immunologist on that group, and there was some interesting emergent stuff in the literature around air pollution, health, and deprivation. The two things that really caught my attention was that there's something about the stress of being poor that erodes the immune system. And that was suggested as one of the reasons why deprived people who are not only more exposed, they're also more susceptible to the effects of air pollution compared to more affluent communities, and that's very clear in the literature. But also, this doesn't relate to COVID. I just, one, do you think that that's sort of an equivalent with COVID, or at least part of the explanation? But also some fascinating work that suggested that there was something about poverty which modified the biological effective dose of air pollutants. So the nasty bits of air pollution were actually getting to the target organs in higher quantities if you were poor compared to being affluent, which is really quite disturbing. No, I don't think there's biological plausibility for that in COVID, but in terms of the erosion of the immune system, do you think that's a plausible, at least one plausible explanation for this difference in deprived communities and in ethnic minorities?
I mean, that's obviously perfectly possible because of the stress response and so on. I mean, even though I guess that's more the arena of medical specialists. But one of the interesting things is that even in the Netherlands, which is not the place where you'd think would be loads of issues around pollution, differences in air quality have actually led to differences in mortality in COVID. There's a fantastic paper by 3 colleagues of mine actually, which examines just this issue. So I think even, apart from the fact that obviously the immune system might be sort of more susceptible, small differences in air quality, even in where the mean level of air quality is actually quite high, have an impact which probably, interact with existing comorbidities and, there are health inequalities, existing health inequalities in the poor, which actually interact with air quality, small differences in air quality. I would like to really see what the big differences are in many countries, whether that actually magnifies the effect, which lead to differences in mortality rates. I mean, I was really surprised to see that for the Netherlands. Yeah.
Yeah. Sid, I couldn't see your slides. I don't know whether that it was just me or whether other people couldn't see your slides. So is the PowerPoint going to, can we make the PowerPoint available?
Yeah, I will. I mean, that could be why people were so stunned, because they couldn't see what I was talking about. I'm sorry about that. I thought people could, but
I could certainly see them. So
you could. I must be.
Yeah.
I must be you then, Patrick.
You must have a filter on me then, Sid.
I've been able to select.
I've
been able to deselect you, Patrick.
Yeah. I have to remember this.
I can see some questions now on the. Yeah, Patrick, it's just you. Then it's okay. Then we don't need to share it.
So there's a question here about there's a couple of questions on public trust in institutions and the relationship there. So how do we restore trust when the trust in the political process remains low? And what effect does the lack of public trust have on or contribute to widening health inequalities?
Yeah. Okay. So there are two very good related questions. So one is, is there a way of building trust in public officials separate from the government? I mean, so when I wrote this sort of blog for the conversation, as somebody pointed out, I might not trust, okay, let's not name politicians. I might not trust X or Y, but why should that necessarily mean that I won't trust Patrick Vallance or Chris Whitty? So I think, scientists, even when working in the government, I think need to be really careful. And I know they are, doing a great job and being independent, but also there mustn't be any appearance of being too cozy to politicians. I think that's probably the reason why sometimes the public can't separate or their trust or their mistrust of government from their mistrust of public officials. So I think that, I think it's really important. And again, there's no magic bullet. And I think people need to start working around, how do you build an independent scientific community? The second, yes, of course, I think it matters about health inequalities, whether it's vaccination, whether it's about willingness to, register with your GP. We know that it absolutely does matter.
Excellent. And just we'll take these two, and then we'll move on due to time.
You're on mute, Andy. You mute.
Thank you. Apologies. I did click it, but it didn't work. Yeah. So I'll just take these two questions that are in the chat, and then we'll move on. So there's a question about why some healthcare workers were vaccinated but not others, and also, and perhaps related, is about the impact of misinformation in terms of the potential factors that affect vaccination levels among lower income households.
Yes, sorry, can you just repeat that? I think it just got lost a bit in the end.
Okay. So yeah. There's a question about the extent to which misinformation around a vaccine contributed to vaccination among lower income households.
Yeah, so I mean, obviously misinformation did. And I think part of the reason why it was successful, though, is because people mistrust official information. So, it's almost like, fake news circulates because people don't trust the sources of, if you like, official news. That's been so we did a kind of scoping study for certain African countries, and it's even more magnified there. One of the things that they've been trying with is kind of looking at, sort of trusted local officials, whether it's religious figures or whether it's somebody else they trust. But yeah, absolutely. I think misinformation matters, but the reason why it has sway is because we don't trust complete information. That's, again, huge topic. Don't have time to go to it, but I actually did something on polarization. I'm happy to send Andy a link to that lecture if anybody's interested, which actually just looks at this question. If there are two people completely polarized views, how do you get them to somehow reach any kind of consensus? I'll leave that as a huge topic, but extremely interesting why, misinformation can hold sway. Thanks very much.
Thank you very much, Sid. That was excellent. Very much appreciated. We'll move on now to Dr. Richard Machin from Nottingham Trent University. So I'll just hand over to Richard.
That's great, thanks, Andy. So I'm just going to share in the chat a link to the paper that a lot of the analysis that I'm going to present is based on. So hopefully everyone can see that, and share my screen as well. So can we see that okay, Andy?
Yes, I can.
Okay, thank you. So thank you for inviting me. And it's interesting listening to Sid there that some of the things that I'm going to touch on in this presentation link really well with the issues around deprivation and inequality that have already been discussed today. So the focus of this presentation is around COVID-19, social security and inequality, reflecting on what's happened in the last couple of years and what needs to happen in the future. So I currently work at Nottingham Trent University, specialising in social policy with a particular expertise around social security policy. I've got a background in managing local government advice services, and I'm also a freelance trainer for Child Poverty Action Group. So I've got those links still with the social welfare law sector, as well as my academic experience. And not too long ago, I also worked for Staffordshire University, so I've got those close links that remain with Chad. So really, the three things that I just want to emphasise in this presentation are to try and unpick the impact of the changes that the UK government made to the social security system as a result of COVID-19, then to look at current public opinion on social security spending. So there's some interesting trends in the public's attitude towards social security, and think also about how the pandemic might have affected those attitudes. And then also present some ideas about how we should be changing the social security system moving forward to really give us a more sustainable system that is more successful in reducing inequality. So overall, then, really, I guess the main idea or basis of my paper is that when the COVID-19 pandemic hit in 2020, the UK social security system was in a really weak place to deal with the public health and financial crisis that we'd witnessed because of a decade of very significant cuts to the social security system that we're all familiar with. So interestingly, the UK government, in response to the pandemic, did temporarily reverse some of the regressive changes that we've seen over the previous decade. So we can see in that second bullet point some of the main things I'm sure you're familiar with. The main UK means tested benefit, universal credit, was temporarily uplifted by £20 per week. There were temporarily more generous housing cost rules, and some more favourable eligibility rules for the self-employed, and a reduced regime of work-related conditionality. And overall, these emergency COVID-19 social security measures were worth a total of £7 billion. But very much, I'd argue that this, whilst in one sense was a welcome injection of investment, it was too little, didn't go far enough, and was merely taking away some of the rough edges of a failing system that has been hugely diminished over the last 10 years. Having said that, I guess we do need to recognise that these emergency social security measures did have some positives and were important for lots of different claimants. So I guess the first thing to acknowledge is that of that £7 billion of funding, 59% of that was allocated to families in the lowest quartile of the income distribution. The second point on the screen there is that the system coped, and I realise that is a bold statement to make, and I'm not overall suggesting that there weren't many people who didn't have problems with claiming welfare benefits during that first wave of the pandemic. I think for me, what was interesting is we've all witnessed over the last 6, 7, 8 years such significant problems with the universal credit claims process. The system didn't fall over, and some remarkable numbers of people did claim universal credit in a really short period of time. So we could see that since March 2020, there have been over 5 million claims for universal credit, and that represents 42% of all the claims made since universal credit was introduced. And also, again, the final point there, whilst not perfect by any means, the job retention scheme and self-employment income scheme, the furloughs, did protect some jobs and reduce reliance for some people on the social security system. The negatives then, so that first point is around creating, these emergency measures created a two-tier system. So it was interesting that the government, we know, did temporarily increase the amount of universal credit for new claimants, for COVID-19 claimants, if you like. But there wasn't a similar increase in the level of benefits for people, so-called legacy claimants, who'd been in receipt of social security for many years. So it created this kind of two-tier system where there was this slightly increased level of benefit payments for people claiming during the pandemic, but no increase for those longer-term benefit claims. The second point is that whilst some people did experience a temporary increase in the level of benefits, the government didn't, during this period, abolish the overall benefit cap. So the overall benefit cap is that ceiling above which no amount of benefits can rise. And so actually we could see that for some people, a potential increase in their benefits was not actually realised because they were already close to or at the level of the benefit cap. For young people, there were some overall improvements, increases in housing support for many people, but not generally for young people under 35s. The local housing allowance rules weren't changed. So that meant for many people, young people who might have found it hard to secure suitable accommodation in the pandemic, we're seeing no increase in government support. And of course, the penultimate point there is that I've mentioned quite a lot this £20 uplift in universal credit. That was a temporary uplift, as we know, which is now ceased. And the Resolution Foundation estimate that that's going to lead to very significant increase in the levels of poverty, as we can see on the screen, and disproportionately affect disabled claimants and ethnic minority families. And finally, the government made no change to the 5-week built-in delay for the first payment of universal credit. So I'm sure people will be familiar that claimants have to wait 5 weeks at the start of a universal credit claim, and the government did nothing to change that with these emergency measures. I think this next slide very much aligns with what we've already heard this morning, what Sid was talking about. So the COVID-19 pandemic, we've heard, has been regressive and had a disproportionate impact on key groups. What I think we've very clearly seen is that, yes, the government were forced to make these social security measures, emergency measures, but they didn't go far enough. And so the system still is badly functioning for women, for minority ethnic groups, for carers, and for disabled people. And I kind of made the point, and that the last point on the slide, not knowing exactly what Sid would talk about, but very much fits with what's already been talked about. Those groups who were not adequately protected by these emergency social security measures, of course, are also then overrepresented in terms of COVID-19 cases and deaths, and deterioration often in physical and mental health, and find it difficult to access support services during the pandemic. So Just thinking of perhaps how we might move forward and turn into public opinion. So polling by the Mental Health Foundation Ipsos Mori found that during that initial lockdown, there's very strong support for the universal credit uplift. 74% supported that change initially. A little bit later, January 2021, surveys from the same organisation showed that there was still support. 59% of the public supported making the £20 uplift permanent, while only 20% opposed it. What's interesting is that there's also some nuance in terms of public perception of benefit claimants, and unfortunately we can see here still very much for many people the kind of idea of the deserving or undeserving poor. So the last point we can see here, there's still very differing attitudes towards different types of claimants. So more support for spending on disabled people, carers and working family, more hostility towards spending on unemployed people, large families and claimants without children. So again, Fabian's study indicates that the public opinion, even on so-called unpopular benefits, it is perhaps shifting as a result of the pandemic. Over 50% of the public do support the 2-child limit for benefits. But alongside that, there's a strong support for working families with a disabled parent and carers. Low support, as we've said, for unemployment benefits, but support for higher payments, which are time limited. The majority of respondents wanted the level of benefit payments for under 25s to be equalised with other benefit claimants. And overall, we can see that there is strong public support for higher levels of social security for people with disabilities, young adults, working lone parents, and lone parents caring for young children and carers. So just to finish off then, why does this leave us? The fallout from the pandemic and some of the lessons that we can perhaps learn from it. So I guess a lot of important policy changes I'm suggesting here on the screen, but all of which I think would be really necessary to put the social security system in a position where it actually is creating a genuine safety net. So certainly increasing the level of universal credit, I would argue even beyond that temporary £20 uplift we witnessed in the pandemic to somewhere approaching 80% of the minimum wage. Certainly very much proposed the abolition of the universal credit 5-week wait and conditionality. We saw in that early part of the pandemic, didn't we, a lot of debate around the inadequacy of free school meals. I think that needs to be, the programme needs to be extended. We have a woefully inadequate social security system for people who are looking after other people, for carers. We need to look at that. And a fairly straightforward change would just be a blanket increase in child benefit. And also perhaps thinking not just perhaps those technical changes, but more of a kind of ideological or structural change. So we need funding for advice service and benefit take-up campaigns. We maybe need to look at, should we move away from means tested benefits to more relying on universal benefits? Of course, we know there's calls for income security, with a fixed amount of money being paid for a period of time, and also to start recognising social security as a human right in the way that it is in Scotland. So just to finish off then, where are we now? So the Fabian Society estimate that if the 2020 COVID-19 measures that have been discussed in this presentation were permanently retained, that would still only return us to 2015-16 expenditure levels on social security. And what they propose is a more generous uplifting of benefits. So to maintain the 2020 COVID-19 measures, but also to restore previously reduced universal credit levels, to bring benefits in for under 25s in line with people over 25, and increase payments for those groups that we've said have got public support. That would cost around 17 billion. Interestingly, that would still only return us to the social security spending levels that we had in 2013-14. And for poverty campaigners, 2020 was always supposed to be a really historic year. Of course, this was the year that Tony Blair's famous pledge that child poverty would be abolished. So, of course, none of us could have predicted what actually happened in 2020, but it's a kind of interest. It could have been an interesting landmark for very different reasons in terms of a sustainable social security system. And what I hope we can see and move forward is that the pandemic has shown us that we can have a swift and significant investment in social security and slow down or reverse some of the most regressive elements of welfare reform. And very much for me, that's what we need to be pushing for in the future years. So I was mindful of my watch there, Andy, so I think I've just about come in time, hopefully.
Perfect, thank you, Richard. That's much appreciated. An excellent set of very practical recommendations at the end there as well. I'm going to abuse my privilege as chair by asking the first question, if that's all right. Certainly, my experience working with people experiencing homelessness in Stoke is that far from being abusers of the benefit system, most people are not claiming all the benefits to which they're entitled. And a big part of my previous work was about helping people to claim all the benefits that they were entitled to, give them a more secure financial footing. But you mentioned in your talk about this two-tier system and people on legacy benefits not getting the uplift during COVID. To what extent would you say that those people on legacy benefits were more likely to have been the most vulnerable or not?
So certainly some people on those legacy benefits will have been the more vulnerable. So people with long-term health problems, people marginalised and socially excluded on a long-term basis. And I think that's why I've kind of reflected quite a lot over the last couple of years about perhaps this perception politically and publicly around who claims benefits and who's more deserving. So I think that was a definite policy intention that the government felt if someone was having to claim benefits because of COVID-19, that was a more deserving position to be in than someone who was perhaps claiming universal credit, who might have a mental health problem, who'd been claiming it for many years. And yeah, it was kind of interesting, not that I would kind of wish that on anyone, but I think, you know, talking to people in the sector working with benefit claimants, how I think many people who were having to interact with the benefit system were kind of shocked and appalled themselves about the paucity of support that the state provides when you have a financial or health crisis. So yeah, I think certainly that if we look at that long-term vulnerability, I think lots of people on legacy benefits would fit in that category, definitely.
Great, thank you, Richard. I'll bring in Patrick.
Thank you, Richard. Outstanding as always, and food for thought. What's your view in this context of? It's quite a broad question. Universal basic income is the case getting stronger? So
I think the case is getting stronger, and I think it's a debate that I kind of keep going back to. And you know, I've worked all my career around a very imperfect social security system, and wanting to kind of try and suggest and campaign about changes that can be made. The ultimate thing that I'm still grappling with, Patrick, is would vulnerable people be better served by universal basic income or a system such as that? Or actually, would people be better served by something resembling the social security system that we currently know, but reformed in a more progressive way? My overall instinct, if I was ultimately given the power to decide, I think I would rather see changes to the current system. I think that could be more targeted. I think could be more effective. But I think ultimately the arguments for universal basic income are pretty compelling, and some of those things around also thinking about it. Obviously, what's clear is that we've got a system that's not working, And so then it's very tempting to say, let's ditch that system and have another one. There is a midpoint where we can make the current system function to a much greater extent, which would mean perhaps the arguments for universal basic income wouldn't be so strong. So, for example, this idea of a reliance on means tested benefits, we could have much more of a universal system within the current system without kind of reverting wholesale to universal basic income. So yeah, I'm kind of persuaded by the arguments, but ultimately I think I say if it was down to me this afternoon whether I would go for that hook, line and sinker, I think I would still have a little bit of hesitation.
Thank you, Richard.
Again, there was a message in the chat which I think asked basically the same question about universal basic income. Are there any other questions? Okay, so we've got another question in the chat. Is there any estimation of the wider economic benefits from increasing long-term provision of universal credit or other welfare to balance the cost of such a policy, and if doing so helps to improve health and well-being and alleviate costs for the health and social care system?
So that question really is asking me to respond to something that I've been talking about and wanting to promote and campaign throughout my entire career. So the simple answer is reliance on a range of health and social care services it is greatly reduced if we have a functioning safety net. So for me, absolutely, the evidence is clear that social security or an adequate social security system creates really good health outcomes for people. The difficulty in one sense is that the research it's kind of so difficult to sometimes pin down those exact incomes about extra money in someone's pocket. What does that actually lead to? And there is an increasing body of research to suggest that. But for me, from what I've seen in my own professional practice, my own analysis, that for people, material deprivation is absolutely 100% linked to poor health outcomes and is absolutely linked to a reliance on health and social care services. And there's a lot of good research been done by Michael Marmot's Institute at UCL around this. So yeah, that's absolutely, I would 100% argue that, and would always be kind of happy to discuss that outside this meeting with anyone as well. So.
Great, thanks, Richard. And I think due to time, this will be the final question. But I think it's the flip side of the previous question, really, and it's about the extent to which a more generous benefit system might disincentivize work, and therefore, would that be less beneficial?
Yeah. So again, I mean, this is a kind of recurring kind of theme or idea that's kind of been put to me working in around the social security system. So a more generous system, I guess ultimately there would be some arguments that a few people might be disincentivized to work. Overall, though, I would reject that as being significant. So for two reasons, really. My experience of working in the sector is that the vast majority of people want to work, and people generally aren't in work because of barriers other than the social security system, whether that's education, physical health, cultural issues. And also, I think that we've seen a kind of system with universal credit that has very much tried to make it difficult for claimants in terms of high levels of conditionality, high levels of sanctions. And having that harsher system has not actually encouraged people to move into work. It's just meant people have been sanctioned for long periods and have lived in material deprivation. So I understand the kind of theory behind that argument, but in practice, in my academic experience, it just doesn't pan out in that way, I don't believe.
That's great. Thank you, Richard. We're right up against time now, so that just leaves for me to thank Sid and Richard for their excellent presentations, and to thank Chad for putting the webinar on today, which I think has been fantastic. I've certainly learned a lot. And I've got a note that Naomi was going to remind people about the next sessions up in the series of webinars. So thank you everybody for attending, and I think Naomi's just going to remind us all what's coming up next. I could be wrong about that.
No, I'm just trying to share it with you. There we go. So these are the next events in the webinar series. I popped a couple of them into the chat earlier, but these are the next ones. And when we send out an email about the recording for this and make things available, we'll share the link for the next webinars as well.
Excellent.
Right, thanks everybody. It's excellent.
Thank you, very much appreciated. Have a great rest of the day.
Thanks everybody. See you at the next one.
Thank you.